Thank you for taking the time to attend our Stage 2 Meaningful Use, What Your C-Suite Needs to Know presentation today. Our speaker is Sharon Stewart, Senior IT Consultant with QHR Consulting Services. Sharon has 30 years of information technology experience, which includes more than 25 years in the healthcare industry. As Senior IT Consultant, Sharon is responsible for clients' hospitals' IT and eMAR assessments, development of IT strategic plans, vendor evaluation, selections, and system implementations. Her primary goal for QHR's IT consulting practice is to provide engagements that foster both enhanced utilization of existing IT systems and high-quality implementations of new systems. And now I'll turn it over to Sharon.
Thank you so much, Sandy. I appreciate the opportunity to spend some time today talking with you about a subject that I am personally passionate about. I have been trying to use information technology to improve the experience of patients and clinicians and the people who support the care that our patients receive for many, many years. And this is truly the point at which we're really going to get to do those things. So I hope that you find this information useful. We styled this presentation as for what the C-suite needs to know. Just to make sure we're setting expectations clearly, the focus of this presentation today is on the hospital objectives. We will occasionally reference the eligible provider objectives where there is some overlap, but we are focusing on hospital today. I wouldn't expect that anyone would go away from this presentation and be able to have memorized what all of the Stage 2 objectives are. My hope is that we'll be able to cover each one of these at a high level so that you can eventually refer back to the presentation materials as a guide and also have information on how to dig into them more deeply. For a hospital CEO, my expectation is that after you see this material, you'll be able to have a comfortable conversation with a physician who approaches you and says, we need to buy these systems for meaningful use, or in order to get to Stage 2, we have to change these operational processes. So I want to arm you with the information you need to be comfortable engaging in that dialogue. For a CFO, we're going to talk briefly about the clarification we have on the payment rules and the penalty rules, and also so that you can understand what the operational implications of doing these projects really mean for your facility so that you can support them. From a clinical perspective, I hope that we have some chief quality officers out there, chief nursing officers, and perhaps even our chief medical officers. The heaviest burden of implementation of meaningful use falls on you. You also can hope to be the greatest beneficiaries of this from the hospital care team in terms of the potential for improved operations, less waste of our personal time in delivering care, and a better experience and better outcomes for our patients is what we really hope to achieve through all of this. And finally, for my information technology brethren, I really would like to leave you with a good understanding of what these objectives actually are, so that when you are asked to support people through making decisions about technology and how to implement different form factors and what infrastructure you need to support them, that you'll have good information about what really is in the objectives and what isn't, but might be a good companion project to go along with that. So what you see right now is a high-level agenda. We'll spend just a few seconds on what meaningful use is. I'm going to give you an update on where you and the rest of our industry are on our progress towards Stage 1. We'll talk about the payments and penalties, and surprise, the Stage 2 rule contains some changes to the Stage 1 rule. So we'll get into the details of that. The majority of time will be spent on the actual Stage 2 requirements. Just want to point this out. This is still a proposed rule. The comment period closed, I believe, on the 7th of this month. And I do have one slide at the very back of the deck where we'll talk briefly about the comments that came in from the different constituents. The finalized rule, CMS is saying that they're going to try to get this out to us by the end of the summer. Based on the amount of feedback they got, that is going to be a Herculean task, but it's possible. So the comment period is closed, but the final rule has not been released yet, so it's subject to change. Meaningful use actually is part of the Social Security Act. The focus of it rests on the 6 pillars that you see here, and these are important not only from a philosophy and policy perspective, but some of the objectives actually refer directly back to these 6 pillars of the outcomes and policy priorities. So we'll see those again, be ready to refer back to them. This arrow diagram actually came from the Center for Medicare and Medicaid Services, also known as CMS, that really describes what the different stages of meaningful use are intended to be. Stage 2 is where we're getting into the advanced clinical processes using information technology. Stage 1 is really about setting the information infrastructure in place to be able to do that. And with Stage 3, this is where we expect to have improved outcomes. I do want to point out that the incentive payments for the use of for meaningful use of electronic health records are focused on using the technology. They are not based on changes in outcomes, at least not in Stage 2. So there is an 80% chance that as of March 12th, you probably had not attested for Stage 1 yet. I hope the vast majority of you are well on their road to that. We have almost 6,000 hospitals in the U.S., and less than 1,000 of them through March have actually successfully attested for Stage 1. CMS does report this information each month, and you can find these reports on their website if you're curious to see how people are progressing. It's interesting that some people are surprised at how small this number is, and others of us who are actually in this business are surprised that we've made as much progress as we have, but I'm pleased to see that. This chart comes directly out of the text of the rule, and they have clarified a lot in terms of what's going to happen in the out years. The information we had that came along with the Stage 1 rule really only went to 2014. So this has made it very clear. The important thing to note here is that if you did a test for Stage 1 in 2011, they're actually giving you 3 years before you have to get to Stage 2. A lot of us were very concerned back in the day that we would all have to be all the way to Stage 2 by 2013 and Stage 3 by 2015, and as it turns out, that's not the case. So the good news is, as the law is written, there are 6 years of payments available all the way through the year 2021. I do want to add a caveat to that for those of you who are deep into the revenue cycle side, and my disclaimer is that I'm an information technology person. But the Medicaid payment can go all the way through 2021. The Medicare payments actually go to 0 through what they call a transition factor in 2016. So now is the time to go ahead and get with the program. And as I said, I hope a lot of you are well on your way to attesting for Stage 1, and that's why you're here with us today talking about Stage 2. Specifically as regards the penalties, this is good news. As I had mentioned a minute ago, we thought that a lot of us by 2015 or 2016 would have to be all the way to Stage 3. That is not the case. The way they did this, and they're required by the law to apply penalties beginning in 2015, but it's a look back. So in 2015, if you manage to get to Stage 1 by 2013, it looks back 2 years and says, okay, you're safe from the penalty. In 2016, it will look back to see where you are in 2014, and if you were a meaningful user in 2014, you can avoid the penalty. For those of you who are not aware of what the penalties are, the first year beginning in 2015 that you're not compliant, you have a market basket adjustment from Medicare every year. 25% of that is already at risk for another pay-for-performance program. Of the remaining 75%, this penalty is going to take a third of that in 2015, two-thirds in 2016, and the entire remaining 75% of your market basket adjustments by 2017. So that really is something to be avoided, and I would really hope that all of us are able to capture as many of the incentive payments as we can. They really do intend for us to be able to use this technology, and they really are turning up the heat to get us to do that. A one-time specific thing that they put into this rule that I expect will survive into the final rule, you can see down at the bottom of the slide, you can complete your 90-day reporting period and capture of information by June 30th and attest on July 1st of 2014. I guess I was trying to give us a holiday there. In order to avoid the penalty in 2015. This is a one-time exception for this period in time. As I said, the beginning in 2016, they'll be doing the 2-year look back. There were stage 1 changes in the rule, and I view all of this as good news. It's very clear from reading the preamble to the stage 2 rule that the regulators who are doing this have learned a lot by listening to the people in the marketplace that are trying to get this done. That would be you and me, and also by the results that they've achieved with stage 1. I think that the regulators were actually surprised about some of the things that turned out to be difficult, and they have really made a lot of changes to try to reflect that. This is an example of that. They had started out by saying that the denominator for this measure would be the number of patients who had one order. And as it turns out, we now think, and I think everyone agrees, it's easier simply to count all the medication orders and achieve the appropriate percentage of that. So if you're attesting for stage 1 in 2013, you can count it the old way or the new way. If you're attesting for stage 1 in 2014, you are required to do this the new way. They made some changes to the requirements for vital signs, and based on the information in the preamble to the rule, it sounds like all of these were done because they are simply clinically reasonable and relevant. They had originally asked for blood pressure for all patients age 2 and over, and as it turns out clinically, apparently age 3 and over is a better place to start with that. So they're making this optional to report this way in 2013, and it will become required in 2014 if you're attesting for stage 1 in either one of those years. They had also asked for the height and weight information for a subset of our patients. They are now saying it's required for all of our patients, which is probably fine because I know that we've been collecting and capturing that information for all of our patients, well, since longer than I've been in the IT business, which is quite a while. The rest of the changes to stage 1, the way that they attempted to get us to exchange clinical information turned out to not be working very well. So they've removed that. They haven't given up on it. It's just different. So they're taking that out of stage 1 beginning in 2013. And before our quality folks get all excited and say, woohoo, they've removed the quality measures, what's actually happened here is that they've taken them out of the rulemaking process. And we'll talk about this a little bit more at the end of the presentation. It's good news in many, many ways. We still have to do reporting, but their approach to it simply makes a lot more practical sense from the point of view of people who actually have to do this in a hospital every day. The next one that they are actually replacing, and I know that some of my hospitals actually bought very large quantities of thumb drives in order to be able to hand these to patients because we were giving them their records. This is being replaced from 2014 onward, not an option in 2013, 2014 onward. This one is just replaced in 2014. So up through 2013, you have to do this the old way, which is good news for those of us that bought a truckload of thumb drives. We're changing over, and I'll talk about this a little bit more when we get into the specifics of the patient communication rules about what that's really going to look like under stage 1. It's the same as it is in stage 2. They've added except where prohibited for submitting immunization data, and on the face of it, it looks like they're making that easier. This is the one that's actually getting harder. What they said before was, if you can, you probably should, and I'm paraphrasing there, and this is, unless it's prohibited by law, you have to. And so that is actually effective from 2013 forward, no optional year on that one. Stage 2 has 16 core objectives, and you only have to hit 2 of 4 menu objectives. Stage 1 was 14 and 10, and so woohoo, there are fewer, except what's happened with a lot of these, and I'll speak to the specifics as we go through the objectives, but some of the things that were standalone objectives that we counted as one in Stage 1 have actually been combined into Stage 2. You still have to do the same amount of work for the Stage 1 things, and are adding on some more for Stage 2. This is a high-velocity presentation. For the things that are fairly intuitively obvious, we're really going to practically bounce off of the slides so that we'll have a little bit more time to spend on the ones that are not as intuitive and are a little bit more complex. We talked about the Stage 1 change for CPOE. The Stage 1 measure is 30%. Stage 2 measure is 60%. Also for Stage 2, in addition to medication orders, they're adding lab and radiology orders. What this has done to us from a practical perspective, I'm not sure how all of you have implemented this. Where I've done Stage 1, we were actually able to just do CPOE in the emergency department, and that was enough to ring the 30% bell for the vast majority of my hospitals. I had a couple where it didn't work, but that got it done for us. That was a lot easier computerized physician order entry implementation doing just the ED than it was going house-wide. What's happening with Stage 2 is in order to get to 60%, there is no way that we're going to be able to handle that by just hitting a couple of venues. We do pretty much need to go house-wide. Fortunately, it's 60%. Because I know that all of us have some areas where this is still going to be very challenging. I have hospitals where the OB system is what they use for the physicians to put their orders in that area, and they've been doing that for years. It's going to be a long time before we can get them to switch over and get that into the core HIS. Based on some of the other requirements, there's a good chance that in order to count these, you really are going to have them do that entry into your central system. Demographics was also a requirement in Stage 1. The Stage 1 measure was 50%. This one goes up to 80%. Two things of interest here. Preliminary cause of death, they've clarified that that is preliminary, and if for some reason that changes later on, which it frequently does after other things take place, we don't have to go back and update these. Chances are you're going to want to for purposes of your medical record, but it's not required. The other thing they've gotten a lot of comments on is disability status. Obviously, the intent of this is to have that information available as patients move to the next phase of their care, and I can see how that would be very reasonable and relevant. The discussion is about how to actually reflect that in the record. So hopefully we'll get some good clarification on that when the final rule comes out. We talked about the changes for vital signs for Stage 2. The same things will be in place. The new version will be in Stage 1. The new version will be in place for Stage 2. And now we have to capture this for 80% of our patients. The Stage 1 measure is 50%. We will continue to capture smoking status. The Stage 1 measure was 50%. We're going up to 80%. There's been a lot of pressure from consumer groups to include all kinds of tobacco in this, tobacco use in this, as well as smoking status, but they did make a comment in the preamble that this is where the population health data is, and so that's what they're going to focus on, and I expect that they'll stand firm on that. Here's one that deserves some special attention. The clinical decision support rule, the one rule that you have to do for Stage 1, a number of us were able to address that by using a fall risk precaution evaluation that spun off fall risk precautions and consultations and appropriate subsequent clinical activities. That was something that nursing documented that our nurses could do. And we've tested that way. We've had external auditors come through and look at that and say that's perfectly in line with what the Stage 1 rules are. In the Stage 2 rule, they have gotten a lot more specific, And there really is no way around having this in front of a physician. So this is part of the overall package of CPOE. It has to happen in between the time an order is initiated and before an action is taken on behalf of the patient. It also has to have 5 of these in place, high priority health conditions. My School of Hard Knocks tells me, and I know that a lot of you probably have as well, had these discussions with your medical staff, the thing that we call alert fatigue, where it constantly pops up. My best advice to you is to engage now with your medical staff to identify the group of people who are going to select these alerts within the constraints of what your technology can do and how those are going to be used. The idea is that we want to provide something that's helpful to the people that provide our patient care, not something that's a barrier to their care and their safety. But they are very serious this time around. There is no way that we're going to be able to do this outside of having the physician actually interact with the computer. So something fun to look forward to for stage 2. Structured lab results and getting those into the system so that we can take action on them. This was actually a menu item in stage 1. The measure was 40%. This is now a core item, and the measure has gone up to 55%. This is probably one of the easier things that we have done. I would suggest, and as I said, farther in the presentation, I have a link to the actual details of the rule. And let me just give you a tip. If you are the person who becomes responsible for looking things up in the rule when your organization reaches a decision point on interpreting an interpretation of how you actually are going to implement these, the notice of proposed rulemaking, the public inspection desk version, which you can access through this link as well as double-spaced. I find it a lot easier to work with, but the stage 2 rule is actually 455 pages. So there's a table of contents at the front of it that doesn't have page numbers. My best advice to you is to take the 10 or 15 minutes that it takes to go through there and actually put page numbers in your table of contents. That will help you a lot. And I would suggest that on this particular one, you have the person who is your lead person responsible for your laboratory information systems and have them actually go out and read the preamble related to this. They have a very in-depth discussion about what to do with results that come back in a text format, particularly from reference labs and things like that, and whether these should be re-entered in order to get them into structured text and trying to balance the risk of there being an entry error or a duplication. So this would be a good place to involve your laboratory information staff. This one is not very difficult. I think most of our systems already do this. It's a population health thing. Is to be able to produce a report that's based on a relevant condition. And I'll leave that for you to work out with your vendor or with your clinical quality folks. You are probably already producing a report that will meet the requirements of this. eMAR. They've been telling us since back before stage 1 that this would be included in stage 2, and lo and behold, here it is. I can tell you that since this was not a menu requirement in stage 1, that a lot of the commenters are coming back and saying you can't possibly do this to us without having it be a menu item first. I will simply offer my own personal opinion on this, which is of all of the technologies that we have available to us to support clinical care processes, the patient safety and financial return on investment for this technology is one of the best that I have ever seen. There are a couple of others out there. If you're not doing this, now is probably a good time to get started. This is a major change for your nursing staff and for your pharmacy staff, and most of our vendors are now pretty good at getting this to happen. They did, in the original form, they didn't include barcoding. They simply would say, well, if the nurse puts some medication administration in the computer, it's okay. I would avoid that at all costs. We need to use the barcoding or RFID, although I've never seen an RFID medication administration solution. I'm sure there's one out there somewhere. We need to be using this now in order to capture the benefit, not only for our patients, but also the benefit for our organization. This is a big change, and for my IT friends, now's a great time to be talking about how you're going to do this. Are you going to have completely standalone handheld devices? Are they going to be wireless, but somebody needs to take a cart down the hall with them? Are they going to be tethered to a cart? Are they going to be tethered to workstations in the rooms? I've seen all of these things work, and it really depends on the care venue and the physical layout of your facility and how you do your medication dispensing and distribution. So no time like the present to get to work on this one. There's benefit there for you and for your facility, even if it has nothing to do with meaningful use. This is what replaced the here's your thumb drive with all of your information on it, allowing our patients to pull down their information. More than 50% of patients have this information within 36 hours of discharge. So for those of you who are the HIM professionals in our audience today, this is something you're going to have to talk with your clinical operations people. Are you going to be able to have all of this coded by then in terms of the required information? Are you going to address it somehow else? And the thing that most people have been concerned about is that they're asking us to be responsible for having people actually go and get this information. And they said more than 10% of our patients, and of course the question is, how do we control these people? How do we make that happen? And I can tell you that a lot of the folks that I've talked to feel that their employees make up more than 10% of their patient population and that they can encourage them to do this, and that's how they plan to meet this measure. For those of you who have had the opportunity with your personal physician or with a hospital encounter to look this information up online, I don't think you're going to have to work really hard to get people to do that if you let people know that the information is there. The challenge is getting the information out there in a format that's useful and appropriate and correct for those folks, and keeping track of who viewed it and what they did with it. Good news on the patient-specific education resources. This one is unchanged from stage 1 to 2, except that it was a menu item before. Now it's a core item. They did clarify that we don't have to store the actual educational materials inside of our core hospital information system. That's good news, because the vast majority of us use some kind of data provider service to do this, whether it's something like Micromedics, and I apologize for mentioning vendor names, but the different products like that out there in the marketplace, or even public domain things like Medline that you can refer people to. All the hospital system has to do is say, based on something relevant to your condition, here's an appropriate piece of educational material for you to look at and actually point at it. Medication reconciliation is one of the most difficult things that we have to do. The stage 1 measure was in the menu set, and it was 65% there. It's still 65%. Just yesterday, I saw something in the healthcare press about lessons learned where, I apologize for that, lessons learned where they tried to automate medication reconciliation. They had a bad process to begin with. I've been involved in this struggle. I've seen situations where, looking at a hospital's paper process, their admission reconciliation was on the left side of the piece of paper, the discharge was on the right, and just as a matter of course, while the patients were in the hospital, the physician was signing both sides of the form. That's not a good care practice. I absolutely do not recommend that. We need to make sure that you have your physicians and your nursing staff and your pharmacy staff and your quality people involved in the discussion about how you're going to do medication reconciliation. And you can't start too soon. Another not terribly successful experiment that I've done with technology around this is to use a third-party provider to pull in information from the pharmacy benefits managers so that you have a better shot at appropriately identifying what medications the patient is taking at home. The difficulty with those solutions is trying to integrate them with your core system. If you don't have all that information together, it's going to make it very difficult for your physicians to do this. The last thing that I will mention, and those of you who are in this business and have worked with us all the way back to when Joint Commission withdrew the requirement because it was so difficult to do. You really need to start now with your physicians to talk to them about how you're going to present this information. Sometimes they want to see all of the home medications in one section and the inpatient meds somewhere else. Sometimes it makes more sense to have them interleaved together in terms of what the physician has to do. The other thing that I've learned that really was kind of surprising to me is that some people think that after a physician does this reconciliation and does the discharge meds, that they actually go back to the hospital pharmacy for review. And that doesn't routinely happen, at least not in most of the facilities that I've worked with. So get this process right, and once you get your process right, then try to automate it. And to the IT folks out there, if we try to automate it and say we'll just swing a tool at it and fix it, please don't let people do that. This is a huge opportunity to do something good for our patients, but we need to make sure that we get it done right. Otherwise, you're going to have physician problems on your hands that are really, really difficult to straighten out. Okay, our next topic is the electronic summary care record. This is what substitutes the old exchange things that were actually pulled out of stage 1. They've gotten a lot clearer about what it is that we have to send, and also about what constitutes a transition of care. So more than 65% of transitions of care have to have this done, and a transition of care does not, for this definition, does not happen inside of the facility. I think of the transition of care sometimes as going from the ED to the ICU or the ICU to step-down unit or something like that. That's not how they define this. The definition is, however, very clear, and we have to hand this information off to whoever's next in the care chain. One of the other challenges, if you happen to be in a community where everyone is more or less synchronized on one vendor's tool, if you see down at the bottom of the slide in the measure, more than 10% of these transmissions have to go to someone who's using a different information solution than you are. So now would be a good time if you have a large independent physician practice or something out there that will agree to work with you on this. Now's the time to go ahead and get those agreements set up with them and be ready for this. The next 3 are similar in nature. There is one for immunization registries, there is one for structured lab results, and there is one for syndromic surveillance information. So all 3 of these, they have changed them to say, except where prohibited. All of these, I believe, are menu items in stage 1, where you could ring the bell if you just got one test, whether it was successful or not. Now it has to be ongoing submission, and a lot of the comments have addressed how it is that we're going to demonstrate ongoing submission. What they're saying right now is that they'll just have these agencies give you a letter so that when you attest, you can file this information with your documents you have that support the attestation. I think there's going to be more to come on that. I don't know that all of these agencies are even in a position to try to do that for us. So it will be interesting to see how this one is implemented. And our last but not least, but still completely unchanged, core objective is the one about security and privacy. And you can see the quote. I apologize for reading the slide. 40% of large breaches involve lost or stolen devices. Had these devices been encrypted, their data would have been secured. So they've bent over backwards to not say that encryption is required. So as part of the rule, you don't have to do encryption. You do still have to do the annual security risk assessment and have any of the deficiencies addressed or have a plan in place to address the deficiencies, which is simply a good practice anyway. For stage 1, you have to do this as well. But you really need to think about encryption. They stopped just short of saying it was required, and there are a lot of technical reasons that they don't want to do that, but it was clear that they really wanted to. For those of us who have done encryption implementations, they take time. They're not technologically all that difficult. It's the same process. You find a vendor that you're comfortable working with. There may be somebody that you have a relationship already who provides this kind of a solution for all of your equipment. But actually getting to all of that equipment to get this done and getting to all of the people who use each of the pieces of equipment, making sure that everybody is in the right situation they need to be to still be able to access it after the encryption process runs can be fairly time-consuming. And the solutions that I'm accustomed to seeing actually materially increase the boot-up time. So if you have physicians who, for whatever reason, have to reboot your equipment in order to get into it under some circumstances, like another user was left logged in there, you probably need to go ahead and solve that problem first. So my best advice to my IT brethren is to please go ahead and get started on encryption. It's just the right thing to do, and it probably is the most comprehensive solution for securing the information for your patients. And for my CFO friends, just make sure that you have your risk assessment scheduled and ready to be done. Let's talk about our menu objectives. There are 4 for stage 2. The one for advanced directives has not changed at all. You do not, and this was a question my organization came up with, you do not have to have an actual copy of the directive itself. You simply need to record whether or not there is one that's available and present for the patient. One of the things I ran into is that we actually asked questions about this in registration and in the nursing areas, and they were recording that in 2 different places. So when I got ready to do my stage 1 report, I had conflicting data and couldn't get my numbers to come out consistently. So you really need to work through that. And this is probably a good point to mention. Whoever is responsible, whether it's somebody in your quality area, in your revenue area, or your IT area, who is responsible for actually doing the reporting to pull the information you need to support your meaningful use attestation, it is never too soon to start deciding how you're going to do that. As soon as you have your meaningful use certified version of your software, go ahead and pull the reports that the vendor gives you and see what comes out of those things. You may find that you think you're collecting information, say, on smoking status. You may be collecting information on smoking status, but it may be in a customized nursing assessment that you built and not in the field where the vendor is trying to pull that information from for your meaningful use report. So never too early to start that investigation. Our second menu objective struck terror into the hearts of some of our people who run our hospital information systems. Imaging results and information, read that as reports, so the pictures and the reports need to be accessible through your electronic health records or your central hospital system. You do not have to store the images in your system. They can still be stored in your PAC system or whatever you use for doing that, but you do have to be able to tunnel through. Personally, I'm very pleased to see this requirement out here because I've wrestled with the vendors who provide the PAC solutions and the hospital solutions to get them all to give me an easy way to make those connections at the actual exam level. And in order now going forward for them to be certified for meaningful use for stage 2, actually I'm not doing it by stage anymore, but for them to be certified for meaningful use, they're going to have to give us this capability. And this is something that really is important to physicians and will make their lives a lot easier. But it is a menu item, and I think that that CMS acknowledging that it may be difficult for some of us to get to know. Another option for us on the menu set is the family health history of structured data, which seems like a perfectly reasonable thing to do. But there are a lot of comments. The same as the disability status, there doesn't seem to be any industry standard way to record this information. So hopefully they'll be able to work that out and come up with something. There were some things that have been suggested in the comments as standards for this, but apparently they really aren't universally applicable. So it'll be interesting to see, and that's their purpose in making this a menu set item, is to see how people actually implement it. Last but not least, let's talk about e-prescribing in the inpatient setting. This is something from a physician satisfaction perspective that I think your physicians may be interested in doing ahead of time if this is something that you can offer them. I've seen this be a real physician satisfier and something that their patients like as well, which also helps to make the physicians happier. If you can get this done in the inpatient setting, and I know there are some restrictions on certain types of controlled substances, so it can't be absolutely universal for everything, but the more of this you can do electronically and get this worked out, especially with the retail pharmacies in the area of your facility, the more success you're going to be able to have. And like I said, this is a good hook for the docs to say, here's something that we're trying to do to make your life easier. And now a brief discussion about our clinical quality measures that didn't disappear from the objective, but here's how it's going to work. So the good news is that they are allowing us to align these. The National Quality Foundation has a list of measures that they keep up with, and there's a measure steward that's clinically appropriate for each one of these measures. So instead of CMS trying to write a rule that goes into the Federal Register that says, here's what this measure is, they're actually now referring back to the measures at the NQ lab. It's not a perfect solution, but it's a lot better. And that makes it much easier for you to align what you're going to report with the things that you're already reporting to Joint Commission and to all of the other agencies. If you haven't yet attested for meaningful use stage 1, I have to say this is far and away the most difficult thing that we had to wrestle with. Actually, in some situations, we ended up self-certifying a separate data warehouse where we were feeding this information because we didn't have all of the data coming out of one system, so we had to put it someplace that we could get certified in order to report it. So also something from a technical perspective you need to be looking at early on and working hard to align this with your existing quality programs so that you're not doing extra work, or even in the worst of cases, I've seen situations where people have actually had to report on a measure one way for meaningful use and another way for somebody else. So hopefully this will resolve that. Thank you, CMS, for making things a little bit better for us. They're still talking about the electronic submission process. They wanted this data to come in electronically. There have been a lot of comments on it, and I don't want to get into too much detail because we're limited on time today, but they really don't have this ready to go yet. They are still talking back and forth about whether our electronic submission is going to be an aggregate number. In other words, I had 300 of these and 200 of those, and therefore here's what my percentage is. Or if it's actually, we're going to have to send you detailed data on all of our patients and let CMS calculate it the way they want to calculate it. They're discussing, is it just our Medicare patients? Is it all of our patients, multi-payer sampling? Lots of things still going on there. They did a pilot program that was for 2012 to try to come up with ways to do this, and I hope some of you out there agreed to participate in a pilot program. I don't know anyone who has, and so I'm concerned that they're not getting good data on that. Here are the details on the number of clinical quality measures. The important thing to note from this slide is that they apply beginning in 2014. Almost all of them apply regardless of meaningful use stage. So just to talk through an example, I could attest for stage 1 in 2013 and use the stage 1 clinical quality measures that are still specified in the rule. In 2014, everything else I'm attesting for in stage 1 is still the same, except now I've got a different set of clinical quality measures that I have to report. So think about that. Think about whether you can actually make all of those changes at once, or if you're going to have to go into this stepwise. So if you get your reporting in line to pull all of your information out of your systems in 2013 and you receive a great big sigh of relief, you may have to do it again the next year. And just a point, I think most people are aware of this, but when I say 2013 or 2014, for hospitals, that is the CMS fiscal year, which starts on October 1st and runs through September 30th. So, for example, the 2013 CMS fiscal year starts this year in October. I have a little bit of information here on comments on the proposed rule. Consumers want a lot more. They want that information available instantaneously at discharge, and they're doing the same thing on the physician side. And we're, of course, saying we can't provide the information to them until we've had an opportunity to look it over and make sure we know that what we're handing is correct. They want everyone to report on everything for the entire year all the way through. The providers are saying, when we get to stage 2, let us do like we did for stage 1 and only do 90 days out of the first year at stage 2 level. And they actually went so far as to say in their comment it was almost a negotiation. It says, and if you can't cut it down to 90 days, we'd be willing to look at 180. So they're trying to show a little bit of flexibility. The other thing that the providers, which are us, are saying is that, you know, if you're bringing a new objective, you really need to put it in the menu set. There are a lot of things out there that you can't anticipate that are going to create barriers that make it, either barriers that make it really hard or things that make it really easy for us as providers to do these things. And you need to give us a chance to select out the ones that we really can be successful with. We all want to move forward with electronic health records. Let us be successful. The vendors made a lot of very useful technical comments about things in the rule that when you look at them from a technology perspective were ambiguous, and so they've commented on that, and I'm confident that all of that will get worked out in the final rule. The other thing they brought up, though, was that please don't make our customers have to do an upgrade every year, because one year I'm stage 1 with 2013 and one year I'm stage 2 with 2014 and I'm having to change, or they don't want to have a lot of different versions causing upgrades. My suggestion to the vendors would be make your next upgrade capable of addressing all these things. Give me the option inside the software to turn it off or on, which I realize is a little bit optimistic on my part, but as an old software developer, I think that that's a possibility. Ready, set, go. 1, 2, 3. CMS says that they're going to have our final rule out by late summer. I guess that means August or maybe September. If it comes out in that time frame, that means there will be only 13 months between us and when 2014 happens. So if 2014 is a stage 2 year for you, we are really, really having to hump it to get there. The vendors have to get all of these new things baked into their software. They have to test it. We have to install it. We have to test it. And then we have to make sure that we can actually get the data out of the system after we get it put in there. So even with the extra time that they have built in for the folks who were in stage 1, this really is pretty much of a foot race. So all of the things you can do operationally ahead of time, I would strongly encourage you. Medication reconciliation, work that process out, barcode medication administration. There's a great benefit available to you. If you're not already doing that, let's jump on it and get it done now. That is the end of my information on the stage 2 requirements. This is a slide that will be in your slide deck about my company and what we do to help hospitals implement meaningful use. This information is a link to the actual rule in the Federal Register. So if you go to the top link that's on the slide, and I understand you'll have these available to you, you can get the actual text of the regulation. You can get to the public inspection desk format, which is the one I prefer. It's double-spaced. I find it a lot easier to write in it and make notes. If you use this one, make sure that you also look at the bottom link down here. There were a couple of places where they skipped numbers or messed up numbers in the way that they labeled things. So if you're trying to use the table of contents, you may end up in the wrong section, or you may not realize that you're in the EP section when you think you're in the hospital section, and vice versa. There's also a complete set of regulations for the Medicare Advantage program. So when you get into that thing and you're doing a search for key phrases, just make sure you know which part of the rule that you're in. The one in the middle, I would encourage the technical folks to actually spend a little bit of time at least looking through the summary and the table of contents. This is where they're describing what our vendor partners have to do in order to be successful at getting their software certified, and there are a lot of comments coming in on that. Okay.
Well, thank you so much, Sharon. We do have some questions that have come into our Q&A. I'd just like to remind everyone, if you do have a question, please type it in the Q&A in the right-hand side of your screen or the chat window. And my first question is regarding Stage 2 menu objectives. Does the PACS system need to be ONC certified technology?
I do not believe that the PACS systems have to be certified, because I don't think that they would qualify, certainly not as an EHR, and I don't know that they even have to have modular certification. I know that some of the vendors have attempted that, and I think the way that they're defining, in the Stage 2 version of the certification rules under ONC, they've defined what they call a base EHR and then modules that are added onto that. They got us wrapped around the axle a little bit in Stage 1, where you ended up having to buy modules from a vendor in order to have all the parts, even if you had no intention of using them. So a lot of us went and did deals with our vendors where we said, would you sell this to me for a very reduced price if I promise you that I'll never use it, and you can monitor and make sure that I'm doing that? And it's the same thing with a lot of those modular systems. So far I haven't seen a requirement that looks like those things have to be certified. So I'm going to say right now my answer is no, but that's subject to change based on what comes out in the final rule.
Thank you, Sharon. For changes to Stage 1, will this be Stage 2 law rule?
I'm sorry, could you repeat that?
For changes to Stage 1, will this be Stage 2 law rule?
Okay. The way I understand, if I'm understanding the question correctly, the changes to Stage 1 actually will become law or regulation as they're posted as part of the Stage 2 rule in the Federal Register. So those things, just like the Stage 1 rule is a federal regulation right now, or a law, if you will, then in Stage 2, those changes to Stage 1 also become law. And if you look at the details of what they've changed, the requirements of the changes in Stage 1 tend to continue into the Stage 2 objectives. Well, let's just do an example. The vital signs change that they did with Stage 1 also gets reflected. It's exactly the same in Stage 2. So they're really making corrections and trying to catch up with themselves. The only difference in the vital signs between the revised Stage 1 rule and the new Stage 2 rule is the percentage of patients on which you have to record that information. So I hope I understood the question correctly, and if not, we'll try it again.
Sure. I thought that the privacy and security measure had a new twist, securing data at rest.
The data at rest has to do with the encryption, and if you read the details of the rules, it's not required. It's just, they strongly recommend it, but they stop one short of actually requiring it. And I'm not technically really sure why they didn't just go ahead and step over that line, but I know that there was a whole lot of resistance. I think there was a lot of concern about the cost of actually forcing people into an encryption methodology, and that would get them off in the business of having to say this type of encryption is acceptable and that type is not. That's really what the ONC panel is supposed to do, is identify standards, and it sounds like they've got some disagreement over there. But the data at rest problem really is encryption, and they haven't said that we have to do that, but they do say that your data has to be secure.
Great. If you are submitting data to a healthcare exchange database, does that cover the exchange of summary of care to a different transition of care?
It depends on who's on the other end of that submission to the exchange. So if you have a release from your patient to put their information into a public utility exchange where it basically sits out there and waits for your patient to authorize somebody else to pull it, I don't think that that's going to count. I think this needs to be an at arm's length transaction with another provider on the other end. Now, if you put it in that exchange with the expectation that, say, when the patient leaves, they're going back to their primary care provider, and you put it out there for the purpose of sharing it with that primary care provider, and that's understood when you do that, I think that actually does comply. So I'm afraid what I'm telling you is yes and no. Lobbing it out there into the exchange just generically to make it available doesn't count. It has to actually go out there with the intent of providing it to another specific provider. The other thing also to remember with this is that requirement that some of these go to people who have a different kind of technology on the other end. So it's clear that in order to meet the measure and report on it, you're going to have to know what the final destination of that information was. So I'd say generically just putting it in the exchange won't meet the requirement that you need to know where it's going. If you get it where it's supposed to go by way of the exchange, that probably does.
Okay, similar to the last question, will the CCD through a certified HIE cover the summary of care during transition of care?
Same thing on going to the exchange, and in the comments there's been a lot of discussion about CCD, CCR, and there is another acronym out there for those of you who aren't familiar. The continuity of care or clinical continuity record or document architecture. They are still talking about what the format needs to be in order to count as doing this exchange. And the comments, which you can reference if you look up the rule, the comments that came in from the CHIME group really got pretty deep into that. The problem is that the standards that I think the HL7 group has put out really were originally put out to support communication between pediatric providers, and they really haven't been vetted for the adult population. And the other thing that the vendors actually said about it was that we know we talked about CCD and CCR. We have to keep modifying our software to meet all of these. So I believe the intent with the rule is if you can get something that's certified, that's really where they're going to specify what that technical mechanism needs to be. So 2 places, in the comments from CHIME and then in the ONC rule on certification. The easier method, short of having to go out there and dig through all of this regulation needs, or whatever the appropriate term is for that, would be to talk with your vendor and ask them how they're interpreting this rule and see. I know that a lot of the folks that work with iEtrics use Meditech, and get them to post information probably on their customer website that says, this is how we intend to implement this, this is how we've read the rule. Personally, I think that using a structured format like that is a great place to start. And if you can actually get it out there in that kind of a structured format, it's probably going to be pretty easy after that to meet that requirement. It just simply has to connect into the other end. And those are the most prevalent formats, even though they really haven't been formalized.
Well, thank you, Sharon. Unfortunately, we are at the top of the hour. We do have more questions here. We will need to follow up with those after the webcast. I guess we could go with one more question, and the question that I do not get to, we certainly will follow up with. The last question here on the CPOE Stage 2 measure, does this include outpatients? We currently, in Stage 1, used ER patients and inpatients, but not our SDS patients.
So the denominator for the patient population is not really changing. If you'll recall, in Stage 1, we had 2 options for that. One was the quote-unquote all patients method, and the other one was, I'm going to say, the observation patients method. Neither one of those allowed us to count our outpatients, and I don't think that they've relented on that. I think it's still ED and inpatients only. From my reading, they really haven't changed that from Stage 1.